maybe that's to balance. It has to be more.
Ba kuma ga dan magana.
O tuti be ko nasti ni kam kaburi.
Wala ture ma wala kirkyo su ta ta. Kullu anon kullu facci sanni. Facci ko o fere ma se to harci se buta. Amma to buti ma yelo ne do ko da hana. Amma ture so sai da wala. La
Diam on.
O jonta obiyo yara?
Do wani.
Saukar da gafa. Saukar da gafa.
Ayi mu saukar da kafan kaɗan tukuna.
Morning. Well, good morning. Good morning, everyone. Once again, sorry for the late takeoff. Good morning once again. Uh, Sorry for the delay. It's due to some technical problems regarding the network and the devices being used for the streaming of the online session. Are you hearing? It's not showing. No, it's showing. Internet is connecting. My internet is showing connecting. So let me try my own network. Airtel, it's not MTN. MTN is it's not showing, but I cannot hear me both. It's still connecting. Let me just connect my. She said about that current I'll come down here so what they did the last time. I have to subscribe for MTN and Airtel at the same time. So this time let's do here with all your gadgets. Assistant class, you are still you are around. Yes, I'm already off. It's MTN or Airtel. Yes. So no, I'm changing back to MTN. Now Airtel. Go. Now I'm saying no, I'm managing. Yeah, I use MTN. Now to start TV when you're buying the Airtel. Hmm? I down you have to be back. Oh, Hafiz, please, can you unmute me? Oh, it's okay. Now? Okay. So, ga mishi sunan nan. Now? Okay. Hmm? Not intending is to good morning once again. Is the volume from? Take I unmute on Hafiz. Anadi? Okay. Good morning once again. I'm sorry for the delay. These are these are result of some technical problems with network and devices, as earlier mentioned. Okay. Okay. It's still around. I can continue. Can you hear me? Is online you can listen to me. Yeah? Okay. Okay. So thank you very much. As we await the slide to display, we can commence. I also thank all of you for your time and for your patience. Thank you very much, and I'm glad to be here once again. Like I mentioned, I was here online for a certain seminar some months back. I'm here again. I want to also use this opportunity to thank the institution for giving me this opportunity. So we can commence the lecture, the workshop proper. The topic, as we all know, as we have seen in the advert, is perceptive neuromuscular classification, PNF. Yes, PNF, which is in full for perceptive neuromuscular classification. But what I have here on the slide, in addition to the nomenclature or the name, because when sometimes we are trying to mention this particular approach, different approach or intervention approach, we tend to address it as PNF technique, PNF stretching, PNF pattern, and all names, or just PNF. Or just PNF. So these are some anomalies in the terminology. Because when we go in deeper, we now realize that we are just trying to capture one out of maybe 20 or 30 or 50 things that PNF is involved. But when you just see PNF stretching, it's just a technique of the whole concept. But when you say PNF pattern, from the name pattern, it's just a pattern of movement that is. So without any other thing. But when you say just PNF, yes, that would be better. But the best way to address it is to say PNF concept, but it involves a lot of. It involves the stretching, which is a technique. So it involves techniques. It involves patterns. It involves a lot of procedures. It involves a lot of other things which you are going to see. Please have this. I would love this slide so that, especially for those that are not here.
Recording in progress.
I think we are back online now. The slide is now available. Yes. Yes. Just like what I earlier mentioned, that the appropriate name to call is proprioceptive neuromuscular facilitation concept. Yes. Instead of just PNF or PNF technique or PNF pattern. Yes, as you can see on the screen, this is one of the information that is going around. For example, effect of the perception neuromuscular facilitation, stretching on physical fitness, physical analysis. You can see that this is stretching is being talked about. It could be that they're actually talking about one of the technique, which is stretching. But we could go further to show you other studies that have been conducted also on PNF, that they are not actually the detailed PNF concept. Yes, we could see that what they mentioned it was that they had a stretching, isometric and static stretching from the beginning to the end. So we can now see another study also, which is effect of perception of muscular facilitation stretching on explosive power and agility. You can even see that the researchers are all from physical education, science, research branch, Islamic University. What I'm saying is they are not even actually therapists. So while retrieving this information online, I'm just trying to give us the idea that we could go online and this information will not be the thing that we are looking for. And I hope by this workshop today, we will do that. If you are looking for any information on the PNF, we'll go straight and we'll know which information we're looking for and where to look for such information and to retrieve it appropriately and use it as possible. This is also another study that is a review. It's putting together all studies that have been conducted on PNF stretching. So this is also stretching that I'm talking about. But this is a study in Nigeria that was conducted by renowned therapists that we all know, Professor Aposhile, Professor Adibuki, Professor Maru, and so on. You can see the detail of the study, that they are even giving information that these researchers that conducted the study had a training by a certified PNF instructor. We could read here in the slide, yes. And they also gave further information, not just stretching. They said that stretching was done, of course. There was timing, manual resistance, and different kind of activities that were conducted. To some extent, this is giving more information than just saying stretching. So I think that is one of the things, because not all the benefit information is available online, and it's not all the information that could be utilized by almost all those that encounter it. So sometimes have to pass through training, certification training for you to be able to achieve this, to get how to have this information. So that's why there are a lot of other information that are just a little of what is supposed to be obtained. So having said that, this is also another study which is just like a review that was written by Greg Smedis. This review was published as a result of all those misinformation. I think the author got tired of this PNF stretching, PNF technique, PNF pattern that's being shared online and being videos being shared in publications, all sorts of media. So the person decided to pen down this information and publish it so that people will have an idea of what is at stake. Yes. You can see some of the information. Some of the things he has mentioned, he said, although the yes, some of the information he has mentioned here is that although PNF concept is part of physiotherapy curriculum in many countries, somehow there seems to be a misunderstanding about the PNF concept. PNF is often seen as a basic stretching regime, like what I just said, for well-being and general fitness. This misunderstanding transferred its own life in modern social media and research, expressed in sports-related studies, such as, for example, from that of Bradley and YouTube videos, he has given a link of it. So it's just like what I just previously mentioned. So even reviews in the field of PNF have mainly focused on the so-called PNF strategy, like what I just displayed. The previous reviews I've just shown, which are published already, and from highly reputable journals. But it's just that the actual information is not what's supposed to housing. So this has been criticized since the result is open of confusion with the overall PNF concept as a comprehensive rehabilitation. So this is the reason why we just decided to come up and publish such information. We can go online and read this and read this information further. I have the relevant literature that I've just mentioned now. The review that I've just displayed now, and also another publication which is talking about the mechanisms, how PNF bring about the effects of all those things that have been seen or heard. Then there is also a very comprehensive textbook by Suzanne S. Adler, Bakers and Job and Bob, which was published in 2008. It's the third edition. Of course, I don't know if there is a new edition, but this is the third edition as displayed in the slide. Yes. So after mentioning all these misconceptions, so I think by the end of this PNF workshop, I believe we will now be try to change the nomenclature that what have you used is PNF concept. Trying to mention what procedure you have used, what technique you have used, what diagonal you have used, what pattern diagonal and technique you have used in further information. Yes. Maybe the PNF searching will probably stop today. Yes. So what is PNF? In short, people said the meaning is people need fun because it's a lot of fun using the PNF. Yes. Yes. Somebody is shaking head. I believe because it seems to be very, very difficult and confusing. Yes. So I think we need to look at it as concept as something that should be fun to use. Yes. So having said this, these are the synopses that I'll be looking at all through the session today. By God's grace, we have definition, we have the brief history of PNF concept, we have the philosophy. There are some philosophies attached to this concept that whenever you want to apply PNF, this philosophy should be guiding you. There are also ways to assess, which I will not dwell more time on it. Then we go to basic principles. There are basic principles also that are guiding you. Then techniques and the movement patterns. So we can now see what you have been mentioning, PNF pattern, just one aspect of it, or PNF technique, just one aspect of it, or whichever way that we or PNF structure, this is also another technique or procedure of PNF. Is it studying? Helpful? but you can hear from me. So we'll begin with the first item, which is brief history of TNF. TNF was developed in the 1940s. Saying that TNF was developed in the 1940s by Dr. Herman Kabat and Maggie Knott. Maggie Knott is a therapist. Dr. Herman Kabat is a medical doctor who puts on physiologists, and they work together to develop the TNF concept. Initially, it was termed proprioceptive facilitation, just here. So they work together. Yeah, this is the picture. They later renamed it proprioceptive neuromuscular facilitation because the third person joined in the person of Dorothy Voss. she added the neuromuscular. That's how it's come about the name, certain neuromuscular facilitation. So in 1964, a Kaiser-Herbert Institute was established at Washington, D.C. in the United States. Harry Kaiser is a wealthy investor. He was one that supported the development of the center, which was named after Herman Herbert, and his name, Kaiser-Herbert. And how it come into being is because he had a child with neurological problems. So in trying to see his child has improved, getting to know or have idea of what Herbert and Maginot were doing, he came to support them financially with the fundings and the structures all necessary to further improve on what they are doing. Yes, it was first used for poliomyelitis and multiple sclerosis. Then, I think the child of Kaiser, I think had polio or multiple sclerosis, and they actually before, but it was among one of these, it was between one of these two, poliomyelitis and multiple sclerosis. The reason for coming up with this, make the facilitation of the concept through Kaiser because of the child. Yes. So later on, they moved to California in 1947 and developed the treatment techniques and procedures. So these techniques and procedures were developed basically. Some of them were developed based on Charles Scott Sherrington's techniques. We all know of Sherrington's principles of Sherrington and his contribution to neurophysiology. He's also a neurophysiologist, a medical doctor, also a neurophysiologist who has worked a lot to provide foundation to neurology currently. Yes. These some of these principles were typical in vision or inhibition, phenomenon of irradiation, successive induction, and many others. So those are basically some of the principles that this concept was based on. So going on with the brief history, later in the 1950s, another institute was established, still in California, but this time around Santa Monica. 1953, Dorothy Boss joined the team. So that was when they added the name. It was in the 1953 when Dorothy Boss joined them. It was initially the neuromuscular proprioceptive facilitation. So when she joined in 1953, that's when they added the muscular, making proprioceptive neuromuscular facilitation. 1956, first book on PNF was written. Then later, Dr. Sedgwick Mead took over the foundation. That the Kaiser-Herbert Foundation. Then later in the late 50s, that was when courses of PNF come into being. And there have been existences then to date, starting from the United States, spreading across to spanning across from the 1950s down to date. There are courses across the world, especially in the United States and the European countries. So the first course was taught in the 50s. Then later it was spread to Europe in the 1970s, where my units traveled to Switzerland to give the first course. That's the first course that outside that's Europe. And since then, Europe has now been the center. First PNF was other courses. In the 1978, my units must away. Good morning once again. Yes, I think we are not able to work online. Yes. Yes, just to recap again, I've talked about the PNF concept as a whole, as the appropriate nomenclature and terminology. That the appropriate name is PNF concept instead of PNF stretching, PNF technique, PNF technique, PNF stretching, PNF pattern, all those terminologies you see. And I even went further to show you some publications that are all yes, they're thinking all things, there are much more than stretching to do in it. Yes. So this look like an appropriate study, or I would say this is an appropriate study that we can see from a very prominent Nigerian physiotherapist, Professor Aposhile, Professor Adegoki, Professor Maruf. They are all known in Nigeria. And this is a study they conducted on PNF concept. And to go further into the study, you could see that they even highlighted that the researchers had training on PNF concepts by a certified PNF physiotherapist. So just looking at details of the study, see here that they have given the information, and they have also highlighted that they were trained by PNF certified instructor. And you could see that they have further mentioned more than one technique. There was stretching, there are some procedures that are involved, command they gave, there was timing, resistance, and many other things they have mentioned instead of the PNF stretching that you always see on the studies or videos or any other media that is out there. I also explained previously that this is a slide of someone who is PNF certified, of course. So he had information on the PNF, and what worries him a lot is that with all this media that is going around about PNF stretching, PNF technique, PNF this and that. So he penned down this write-up and they publish it. So I read this earlier and I'll read it again. This is what he said. Although the PNF concept is part of the physiotherapy curriculum, in many countries, somehow there seems to be a misunderstanding about the PNF concept. PNF is often seen as a basic stretching regime for well-being and general fitness, which is not. This misunderstanding transferred into its own life in modern social media and in research expressed in sports-related studies, such as, for example, he is now citing one of those studies that were published. He now cited Bradley et al. And he also cited a YouTube video that is online too. So this is basically, he's trying to clear the air. He's just trying to take away the abnormalities in the terminologies and also in the content of the PNF. So here are some relevant literature. The one I just talk about now is the second literature here on the second on the reference list. The first one is also a very important literature which talk about mechanism and effects of PNF. Then the third one is a very comprehensive text written by Suzanne F. Adler, Beckers, and Bock in 2008. Like I've mentioned, this is that's the third edition of the book. This book is freely available online. You can browse PNF in practice. You are going to see it online, and you can read every bit of it. It's very, very comprehensive. So, talking about the problem with TAM, what is PNF now? I've earlier mentioned this, that PNF means people need fun. And somebody here almost disagree with me that because there is no fun in PNF because of how difficult it is and how confusing it is. So PNF, people need fun. So going forward, these are the synopses that we are going to be taking through. So Harry Kesa now supported the work he observed that Dr. Cabot and Maggie Knott were doing. He became interested and began to fund it and later established the Kesa Cabot Institute. One of the reasons also his child is having neurological problem, and he also wants to see his child get better. And he went on further with the support. I said it was first used for poliomyelitis and multiple sclerosis, which is one of the child of of Harry Kesa. Yes, still on the history. Dr. Cabot and Maggie Knott, they moved to California in 1947, and they developed the treatment techniques and their procedures. These techniques and procedures were developed based on principle of Charles Scott Sherrington's technique, which I've talked about earlier, that this is a very popular person in neurophysiology or in physiology or in medicine generally. He has done a lot of work in establishing medicine, yes, especially neurology. Yes, he has some principles then which are reciprocal inhibition or reciprocal inhibition, phenomenon of irradiation, successive induction, and many others. These are some of the principles that were used to base PNF concept. So Later, in the 1950, they established another institute, still in California, but this time around Santa Monica. So later in 1953, Dorothy Voss joined them, and that's when they have the third name or the middle name, neuromuscular. In 1956, the first PNF book was written. Then Dr. Sedgwick Mead took over the foundation, the Kesa Cabot Foundation. Then in the 1950s, still, the first course was taught, first PNF course. And like I said, since then, there have been courses across the United States, across the globe, and especially in Europe, yes. There are a lot of institutions, just like Ray Rehabilitation Institute now, that they usually have courses of different activities, be it on BOBAT or PNF or joint mobilization like Mulligan, Sirius, and so on. So these institutes are now very common in Europe and also in the United States, many other advanced countries. So this is the first course on PNF in the 1950s, yes, in the late 1950s. In the 1970s, the course moved down to Europe, and the first course was taught in Switzerland by Maggie Knott. 1978, Maggie Knott passed away, and in Yes. In 1950, another institute was established in Santa Monica, still in California. In 1953, Dorothy Both joined the team, where she added the third name, neuromuscular. Usually had perceptive facilitation until when Dorothy Both joined. That's when we have perceptive neuromuscular facilitation. Then in 1956, first book was written. PNL book was written. I think this is the first book. But like I said, there are very comprehensive and excellent books now, which I've given earlier the reference by Suzanne S. Adler. It's a very comprehensive book that gives all detailed information on how you are going to make contact with patient, how you are going to plan treatment, how you are going to execute treatment, how you are going to choose the techniques, the patterns, every bit of what you want to do. That book has done. They have done a very excellent job. The Sedgwick bid took over the foundation in the 1950s. In the 1950s, first course was taught, that's in the United States. Then later, around the 1970s, this course were taken to the Europeans, beginning with Switzerland. In 1978, Maggie Note passed away. In the 1990s, IPNFA was established. That's International Proprioceptive Neuromuscular Facilitation Association, IPNFA. I've mentioned earlier that this association are those that regulate the update information and the courses that are being taught. These are the institutions that certify any therapist that has the international certificate, PNF. So all the courses that are ongoing across the world that are being carried out are being regulated by this IPNF. They approve of institutions that train and give these international certificates. Okay, coming down to the history of where I trained, because that's where I will have to complete the history. Where I trained my PNF was in Poland, yes, and the first time they had PNF certificate course was in 1997 by a senior instructor, Inge Berlin, and assistants Maciej Krawczyk and Alexandra Lisa in Warsaw, that's the capital of Poland. I've mentioned that one of the rules of this if it's termed international course, then it means the doctor will have to come from another country just to fulfill the name international. And we can see that the instructor that there, the first course I mean is Inge Berlin. Yes, it's coming from Germany with assistants of who are Polish, right? Maciej Krawczyk and Alexandra Lisa. So later on in 1999, Alexandra Lisa became the first instructor in Poland. So it means you can travel outside Poland and go and train others. And other people will come into Poland to train them. That is the IPNFA. Many other courses too that are international certificates that administer international certificates. So this is how the course look like. Yes, to have the basic course, you have to pass through stage 1 and 2, which takes about 100 hours of training. Very intensive course. It's 8 to 6 daily for weeks. Exams and practical session and everything is very, very intense. Yes. So followed by 3A or 3B, then advancing to 4, and final stage is 5. After this, that's when you now train under international instructor, which you are going to be assisting, like what I just showed Sandra Isak here and Krawczyk. They were assisting Berlin, or he now became also a instructor. So what does it entail? In the first one, there are the basics, the patterns, the techniques, the applications, and so on. Then 3A, maybe there are advanced courses also. And the 4 is involves specialized training, orthopedics, technology, or in spinal cord injury. Then the last one is a training for instructor. You have to write an exam, pass. You have to go outside. You have to train that international instructor. Then these are the IPNFA contacts. That's the International PNF Association contacts. I've mentioned earlier to those in the physical attendance here that you can see from the map. Literally no contact in Africa. They're all concentrated in Europe. Yes, there are a lot of courses in Europe, a lot of courses in different regiments or different intervention approaches. It's about mobilization techniques like and CDF. Many of them, they are highly concentrated in Europe. So very, very expensive. You can see in Africa there is no contact. You can see in Asia and the US, they are common or they are available. So coming down to the second item of the synopsis I've mentioned is definition. So we have the first receptive, means stimulating sensory receptors. Yes, stimulating sensory receptors, which is information concerning motion and body. Well, we all know this. Then the second aspect, which neuromuscular, which is added by Doretivus, activating my neural tissues. Then the last aspect, application, that's just an English word to make things easier or to make things effective or to make things better. Yes, that's just the English term. Putting this together, we now understand what PNF means. So the whole concept is about just what I've mentioned earlier as the synopsis. We have the philosophy, we have the basic principles, we have the techniques, we have the movement patterns, there are gait rehabilitation, there are math exercises and so on. But this is not part of the synopsis we are going to look at. This earlier, rehabilitation will not be there, but we can take some math exercises. Yes, we can now see that from the term we have been see this, all of them comprise and make up the concept. That's why you don't sum it PNF stretch patterns. So we now start looking at them one after the philosophy. First item of the philosophy is PNF is a positive approach to the patient. Positive approach in the sense that you give positive examination and evaluation, activity patient is able to perform. What you do is you always look for that little thing that is left for the patient. Not just the negative aspect we look at patient that he cannot do this, cannot do that extent. What is the little he can flex? Then you facilitate. What is the little he can do? Then you improve on it. So you need to look for those things. That's the first thing that you do. You can look for the thing that you want to close the gap and improve on, or you want him to, as a goal that you want to achieve. Like because he cannot do this and you want to make sure that he's able to do this at the end of your rehabilitation. But you have to look for what are those little things that are available, what those little things that are left on the patient that you can improve on. That includes the psychology, motivating the patient, making it pain-free. When patient comes and begin to make it intense, pain-free, is shouting and all those things, then it's not the philosophy of PNF. So we look for what is able to perform. Yes. Then the second philosophy is mobilization of patient reserves. It's almost similar to what we talk about. It's just a continuation. Yes, but have to make sure the patient is participating actively all the time. He needs to be active every a decision you take, in everything you want to do, you need to understand it. You need to break it down for him. You need to understand it, and you need to participate. You need to also give training in a variety of forms. It need to be fun for the patient. That can be motivated to participate actively, and also the participation could be at home by himself, at home with assistant of family, or in the clinic. Anywhere it is, you need to be actively participating in the management. Then the next item of the philosophy is functional thinking. Everything about PNF needs to be goal directed. What do you want to achieve with the patients? Then you plan. You need to execute, find out how long do you want to achieve this? What are the techniques? What are the patterns that best suit this patient? Then you apply those principles. Then you look at the patient as a whole, also holistic approach. At him as a whole. Human, yes. This is the problem. You assess and also you treat. The use of motor control and motor learning are all very familiar. In the assessment, yes, we look at the based on the ICF, we look at the body tissues and the functions and what is impaired, those body tissue and functions. Look at the activity and the limitations of those activities. And we look at the participation and the restriction of those participation. Because if we manage patients, you only strengthen, and the patient cannot do what is obtainable. Then patient cannot participate, patient cannot actively get involved in the household activities, cannot go out to shop, cannot go back to his work, he cannot go for shopping, all those things. Then you need to do more. You need to find out what are those problems at each of those levels. Most time we tend to dwell much on patients' body functions and structures. Muscle just went here. Strength is okay, but what would that strength take us to? That is it. So we need to find the appropriate instrument to assess those things. We also have some contextual factors that affect such things, like environmental factors, cultural factors. We also have to look into them and assess. After all this, there is an assessment and treatment card that was developed by Maggie Knott. It's a very comprehensive. This is just a summary of it. Have the bio data, the patient, have the assessment of impairment, like I just showed in the last slide, activity limitation, participation, short and long-term treatment goal. Treatment, the trial treatment and its outcomes. It's not just, also on the assessment. Assessment, you can't, if it's not possible that you have completed your assessment today, you can complete it tomorrow. Don't be in a hurry, in a haste. You finish up everything today. Also execute treatment. Also expect outcome. We just hurriedly do some things. Not our fault sometimes. Workloads and many other things that are the factors. But even as at that, we can have it in a divided sessions. You're able to complete what you're able to get, or you're able to achieve, you're able to arrive at certain conclusions. Next time you come, you complete or you reassess again and find out what is missing. Continue. So then also your treatment. You now apply in a trial, and what do you see as the outcome? Is patient okay? Was it painful? Not just that, yes, this is a technique that I feel is best. And you start until the end, you have to be using those things. Just use as trial, which is okay. Then you continue. And you need to also keep on improving or modifying it as the case may be, as the patient is improving or so then the main treatment and its components. I think we had some lectures with I think student asks if you apply PNF, what do you document? And I told them I usually see PNF being documented, and sometimes they even use maybe interchangeable PM/PNF. And when I see that before my course, yes, I think it was okay for me then when I was reading, but after the course, when I went into files and I see PM/PNF, I say, okay, maybe these are the same thing, that they are synonyms also. But I now begin to explain to them that, okay, if you say PNF now, the upper limb PNF you apply for lower limb PNF. Upper limb PNF or lower limb, which of pattern you have applied, which of the diagonal you have applied. And come down to that, just summarizing the PNF itself on patients, just doing the stretching, like usually. So I believe by the end of this session, I'm able to get this. Like somebody was talking to, like I said, it's a very intensive process. Learn a lot of things for an extended period. I'll try to summarize some of the basic things that inshallah, at the end, pick up any text, any information you want to look for. You need to know that this is directly what I'm doing. When you're able to read or watch, you now understand that this is what it is. So the next item on the agenda on the synopsis is the basic principles. I've talked about the philosophy that will guide us. Positive approach, active participation, listening approach. Then we now have the basic principles. The basic principles are, they are supportive. Guiding emotion, agree, appropriate manual assistance. Because most of the times, there are times that you just give instruction and going to be free. Most of the time it's hands-on. These principles guide you on how you grab the patients, how you will guide you all through making the movement or the concept as a whole. They are helpful to patients. Yes, we are back. Like I said, these basic principles help in administering this technique appropriately, is without costing too much fatigue, maximizing tensions. Some of these basic principles are stimulation of exteroceptors, stimulation of proprioceptors, then the procedures itself. Let's start with the stimulation of exteroceptors. Stimulation of exteroceptors begin with first the tactile stimulation, physical contact between your hand and the skin. Usually it's called the manual contact, tactile stimulation, or the manual contact. That's usually the appropriate name. Usually is in the form of lumbrical grip position, just like in the picture. Lumbrical grip. This contact sometimes is not just with the patient with the hand of the therapist and the patient. Sometimes it could be with other instruments available. Use TheraBand, use the ball, use the parallel bar, to use all gadgets around for your own disposal. So it's just the contact with the patient. You have to be cautious of how to make contact with the patient. So what is the goal? What is the goal of this manual contact or tactile stimulation? The goal is stimulation of patient's skin receptors. Like we have said, it's exteroceptors. Facilitation of direction of movement. You make the graph, then that's when you can lead the patient that this is where you want him to go, and this is where you want him to stop. This is how you want him to do it. This is how not to do it. Also, not just how to do it, also not how not to do it, and so on. So that touch also gives sense of protection to the patient, that he's not just lifting his upper limb and he's just going to fall down, and he's going to get injured, especially for those with problem with healing, diabetes mellitus, may fall down in the limb, or fall down and hit somewhere else, got injured, and problem with skin or healing. So you have that sense of security, protection when you pull apart from the stimulation, and also help in guiding the. Then also if there is need for resistance, you also apply resistance. Also help you in appropriate resistance application, manual resistance. Then the next form of exteroception, or the stimulation of exteroceptors, is the auditory stimulation. Give verbal command. Those are the things that help in guiding the application of the PNF concept. Stop. Go on. Go further. It's okay. Okay. No tension. Don't lose the tension. Those kind of instruction. Do more, do more resistance. Those are the instructions, just for him to understand and do the appropriate thing. What are the goals? Draw the patient attention on the motion that is expected to be performed. This is the direction of movement. You are using your hand to help you make the movement, and you are also saying it verbally. This direction of the movement. Move your hand towards the wall. That gives you a very precise instruction. He was lying towards the wall. Maybe the wall is behind, or the wall is by the side, towards the wall. For example, it's easier than saying, because some of this instruction is easier for us if we are making this workshop now. But we go to real life patients. You say flex, the patient will be looking at you. To draw patients, the second item of the exteroceptors is the auditory stimulation. That's the verbal command, verbal contact, or the command. The command you give to the patient, they should be precise. The patient should be able to understand. Take the hand to the wall, take it to your head, take it to your various places around. You make reference to, so that he clearly understands what you mean. Like I just said, you have to make sure that the instruction you are giving, you understand it. Because, yes, when you are talking to the patient, it's not like talking to a therapist now. Telling flex, extend, interrotate, extend, supinate, abduct, adduct. These are terms that are advanced that you will not understand. But you try to explain this in the context that the patient will understand, and you'll be able to do it precisely. So what are the goals? To draw patients' attention on the motion that is expected to be performed. You clearly state to him that this is what you want. There's the manual contact, physical contact with the hands, in which you are going to guide the patient on what he's doing, and also plus verbal command. And to stimulate motion activity, short, clear command, short, clear. Just make sure that he understood what you're trying to say. Then those so relax the patient. That's if you want him to relax, or you want him to give a very strong contraction. You want him to relax the contraction. You want him to completely relax. You want him to, whatever you want him to do, you give the commands clearly. Then to analyze the patient's verbal behavior, abilities to participate in logical movement. You are talking to also understand. Following command is understanding what you are saying. If not, you just be doing things and it's not getting it. And one of the philosophies is the patient needs to be actively, cognitively used. Even if you are making the activities passively, he needs to be following you up. He needs to be watching it. He needs to be seeing while he was making the movement, not just the not just making the movement. He needs to also watch it. And I think that's the next item we'll be taking. That's yeah, still still on the command preparation. They kind of prepare patient, explanation of desired motion, preparation of an action, like distal to proximal, support with initiation of movement. It's help in the, it makes it easier. Correction. Don't stop, don't do this. Don't lose tension. Go on, go further. It's like you are correcting the patient. So it depends. You want to prepare them, give instruction. You want them to take action. You want them to be active on something. You give them instruction of how they take their action. And sometimes the auditory stimulation is also to give instruction, just to correct them on that. This is not how to do it. Don't lose it. Don't lose tension. Don't flex. Understand? Straight. Don't bend. If that is, if you want to, if instruction is to be straight. So then we have the visual that I've started talking about. The visual stimulation of esteroceptors, or the stimulation of esteroceptors, which is the visual aspect now, the visual stimulation. They are related to patient's body. You watch what the patient is doing. You also watch the surrounding. Is there any distraction that he's not following what he's doing? His attention is somewhere. You also watch his own gesture, his own movement. Is it too painful? You can see him squeezing his eyes. You can see him, he's a person that wants to be strong. Doesn't want to shout, doesn't want to complain, but he's just enduring the pain. But he's showing the facial expression of pain. So that was the need for the visual contact. And also, that's usually the relationship between the patient and the therapist. Watch how he's doing it. Watch if there is what is the outcome. So visual motion coordination is necessary for ADL. So just like in motor development, usually watch tasks observation. You learn by observing tasks. I've also mentioned it earlier that if he's also making the move, hit upper limb, lower limb, any activity is doing, try as much as possible, unless the anatomy will not allow you to view. Or sometimes you can even use mirror front just for him to watch how he's making the. That also helps. So yes, to make sure that there is no pain, to make sure you are observing the greater resistance, because if you are giving the resistance that is too much, it's painful. And so now the stimulation of the proprioceptors or the proprioception is done through resistance. Resistance can come through the manual contact. Talk about earlier, like grabbing the body parts through the exercise you are giving, give resistance, or from the environment, just you can use the wall, using the wall bar, using the TheraBand, using all form of ways that you can give resistance. And also, you consider the different types of muscle contraction. Different types of muscle contraction. You have the isometric. I'm going to shed more light on. I want to also talk about, yes, the isometric, isochronic contraction, the eccentric, concentric muscle. And the resistance you give is in 3 dimensions, because most of the patterns, especially for upper limb and lower limb, they are diagonal. They are not just diagonal, but there is 3 dimensions. Because, for example, when you take shoulder movement, take, for example, flexion, and external rotation. So it's not just coming diagonal, but as the shoulder is moving, it's going in 3 dimensions of flexion, abduction, and external rotation. Just example. External rotation. Don't worry, we're coming down to the patterns. I'm just giving an example. It's external rotation. External rotation, the flexion extension as well. So I'm just saying it's 3 dimensions. It's not just 1 dimension. You just move from one axis, from one angle to the other. So you make sure it's going in 3 dimensions. While you are coming, what's happening in the shoulder is not just coming as flexion. Flex for one, then you adduct, you adduct, and you are externally rotating. When you look at it, it's external rotation. When you take it out, it's not because it's looking like coming inward, the rotation is external rotation, but we thought it's internal rotation, but it's external rotation actually. So you can give traction also to stimulate the muscles. Also give appropriation. You can give stretch. You can do a lot of things to stimulate the proprioceptors. Yes. Now, yes, I promise. Yes, manual resistance is usually optimal. You don't give too much resistance to the extent that the patient cannot move at all, unless you wanted to say, except that you wanted the resistance to be static, isometric. Yes, then that's when have it static, but it should be optimal. It shouldn't be too much resistance that, because you are a very strong person and then you are now displaying your strength to the patient. It's optimal. That's why the name is optimal. So apply against all components of, like I said, should be applied to the flexion, to external rotation, and to function. Not just you apply resistance to flexion. We apply resistance to external rotation. We apply resistance to the abduction. All 3. So it's possible in all the contraction: symmetric, eccentric muscle. What is the essence of the manual resistance? To facilitation of muscle sensation and motion awareness, increasing strength. Yes, no resistance, increase strength, of course. But the resistance is in different form. So increase motor, so increase coordination. It depends on the technique and how it's being used. Then stretch also. I've mentioned stretch already. I also give stretch in your task. or throughout while you are making the movement. It's called initial stretch or re-stretch. Then the movement patterns. Yes. We have the initial stretch, which is given at the beginning of movement, or re-stretch, which we give all through the movement that you are conducting on or the concept you are applying on the patient. We have the movement patterns. On the procedures, we have the movement patterns, we have timing, and we have body mechanics, radiation, and you apply patterns, which is mostly what we usually apply, and we have timing. We'll talk about the patterns. They are in 3 planes. Of course, I'll talk about sagittal, whether it's flexion or extension. Have in coronal or frontal plane. That's example abduction, adduction, lateral flexion of the spine. Have the transverse plane, which is rotation. So all these together is supposed to be diagonal, but in spiral, right? What I've just mentioned. There are different patterns. Have the neck patterns, head and neck patterns, have the upper limb patterns, have the lower limb patterns, have the scapular patterns, we have the pelvic patterns, we have different combination of patterns. Find head and neck, upper limb, find upper limb and upper trunk, and combine lower limb and lower trunk, and combine upper limb and lower limb, and combine the 2 upper limbs and make a combination, and make combination of lower limbs. You can make a combination of scapular and pelvic patterns, whichever your choice. Depends on the patient's condition and what you want to do. We should be looking at them one after the other. Movement patterns. Usually they are in diagonal, and that's why they are termed diagonals. Diagonal 1, diagonal 2, all these D1, D2, they are here. That's where it comes from, because they are diagonal. And now, right, when you look at typical person walking, is walking on the first diagonal, D1. By extension, if you extend the movement, most look like the first diagonal of movement. We walk and the lower diagonal. That's where the first diagonal is derived. The second diagonal is usually movement patterns that support us. When you are holding something, want to go, when you are carrying up something up, digging, you are playing football, you want to hit football, That's lower limb that is supporting you while you are standing. So that's how the second diagonal got derived from. So there are always first and second diagonal. That's diagonal 1 and diagonal 2. I want to stick to diagonal 1 first. We go further, then we can come back later for the diagonal 2. So first diagonal, like I said, they are the extension of how we walk. So if you look at the upper limb pattern, it doesn't, it's yes. When you look at the upper limb pattern, it's flexion, abduction, and external rotation. That is flexion, abduction, like I demonstrated earlier, flexion, abduction, and external rotation. If you are walking, flexion, abduction, and external rotation. And the reverse is extension, this is extension, this is flexion. This is flexion. I know the confusion has started already. This is flexion. This is flexion, yes. This is flexion, but the upper limb is adducted. So that's what I'm saying: flexion, adduction, and external rotation. You understand? Flexion, adduction, read it there. Flexion, adduction, and external rotation. So the reverse is extension, abduction, and internal rotation, right? But what's happening at the scapula is we have anterior elevation while you are going forward. There's anterior elevation of the scapula. Then you have posterior depression of the scapula. Can you see that? While you are going into the first diagonal, this is the first diagonal of upper limb. I'm not coming to the upper limb pattern. I want to introduce us to scapular pattern. Please don't worry about all this extension, flexion, this confusion stuff. Please don't worry. I just want to introduce us to the scapular pattern. That's what I want us to take. When you do the first diagonal, is extension, flexion, is flexion, abduction, and external rotation, right? And the opposite, right? So while you are going into this, is you have anterior elevation of the scapula. You have posterior elevation of the scapula. That's how we have the scapular pattern. Have anterior elevation, posterior depression. So if you want to apply the scapular pattern, you can isolate it from the upper limb. You begin with the scapular pattern. Anterior elevation, this direction is posterior depression. Is it clear? Don't worry about the upper limb pattern. I'm coming down gradually. I just want to break it down to the simplest I can do. So we are going to look at the scapular pattern of D1. D1 scapular pattern into anterior elevation and posterior depression. Is it clear? So let's go back to our previous slides. Yes, about patterns. You can see in the slide I've mentioned, yes, there are upper limb, lower limb, scapular. I'm going to break it down gradually so we get to where we want to understand. Have the first diagonal and second diagonal. That's why we have. That's how we have this anterior elevation and posterior depression. Right? That's D1. Forget about the D2. I'm only taking come back later. So that's anterior elevation and posterior. So how is this done? You can take sessions. So what are the uses? You can see it is related to the upper limb pattern that I've just discussed now. Adduction and external rotation, right? anterior elevation of the scapula. Goals is shoulder pain, trunk rotation. Together, the scapular and pelvic patterns, be it the one or the two, do a lot of trunk exercises. A lot of trunk exercises using different techniques. I'm going to do that. Try to demonstrate that. And do that on mat, that on couch, you can do that different platforms. So all you see about scapular pelvic patterns, most of them is about trunk. Most of them is about trunk, you see. However, it also helps in facilitating the upper limb function. Because the upper limb is based on is dependent on the scapular strength and mobility. Muscles around this scapula. Upper limb activity, the whole of it is dependent on the scapular muscles that are around, yes, their mobility, their strength, their coordination, and so on. So, for you to have an excellent upper limb activity and function, this scapular pattern is very, very key. For the lower limb too, also, for you to have excellent Yes, this is the scapular pattern, which is related to the upper limb, like I've just mentioned, which is related to the upper limb D1 pattern, flexion, adduction, and external rotation. So you flex, adduct, and externally rotate. Other movement you have in the scapula is anterior. You do the opposite, which is the extension. You have extension, abduction, and internal rotation. You have posterior depression of the scapula. That's how the scapular pattern is derived that of D1. That's what I just described in the previous slide. D1 scapular pattern as anterior elevation, posterior depression. And I've just mentioned while offline that offline that the name of the pattern, see, is usually the end product, what you want to achieve, where you want to stop, where you are coming, and where you want to end is the name given to the pattern. Starts from extension, abduction, and internal rotation of the upper limb to flexion, abduction, and external rotation. So if this is what you want to do, if all your techniques are your aim at the muscles, the movement in the direction of flexion, adduction, and external rotation, then that is the name of the technique. Flexion, when you see flexion, adduction, external rotation, it means you are starting from the opposite and you end at those. It means those muscles, those movements are what you are interested in treating. And from that, we derive the first diagonal in the pelvic, in this scapular pattern, that is D1 anterior elevation and D1 posterior depression. And we can see from the picture here, which is anterior elevation of the scapula. The therapist is resisting. Yes, I can tell that he's resisting the anterior elevation, but we'll come to know that after the practical session. We'll face how we give the movements, plus in addition to techniques that you are going to use. So usually, I also mentioned that this pelvic scapular pattern, when you combine them, they give a lot of the products usually is trunk exercises. So most of what you see the uses for scapular pelvic patterns, most of the time see in trunk. And in addition to the improving of the upper limb function, or if it's pelvic pattern, the lower limb function, because the very excellent upper limb function lies on the strength of the muscles around the scapula. It relies on the coordination, all the strength, the endurance, and any other attributes of those muscles around the scapula. Same thing with the lower limb. We need to also have an excellent gait. Because you need the pelvic, very excellent and well coordinated and strong pelvic movement. So you now have the second movement. If you go into anterior elevation, the other movement is good opposite. You go into posterior depression, and that's why we have posterior depression here on the slide. Everything is in combination with pelvic patterns. They help in walking, because the upper limb function, the one is what replicates how we walk. So if the scapular pattern is excellent, the upper limb pattern will also be excellent. Gait can improve. We swing our arms. So I said also it's very excellent for trunk exercises, for scoliosis and many other things. This is the posterior patient. D2. I don't want to go into D2. Let's pick up a technique and see how we can apply on this anterior elevation. So there are a lot of techniques that can be used. The management using PNF concepts. Techniques use different muscle contraction, eccentric, that's isotonic contraction, eccentric. It uses also a lot of isometric contractions on what you want to achieve. And the resistance, of course, the resistance can come from filing the other instruments available. The choice of techniques depends on the need of the patient. Do you want to train coordination? Do you want to strengthen? So those are how you can choose techniques. What are the goals of these techniques? Facilitation of movement to make it easier, of course. Increase range of motion if that's what you want to achieve. Relief of pain if that's also what you want to achieve. Also relaxation if also is your target. Endurance or strengthening. Whichever one you want to pick, you look for the appropriate technique that suits for strengthening, or appropriate technique that suits for pain relief, or relaxation, or coordination, or endurance, and many of them. So I'll talk about muscle contractions. This is something that we all know, but I want to just add some details. Muscle contraction that we know. Have the isometric contraction, which is static movement, of course. When there's no change in length, of course, in a wall or just standing, or your muscles are co-contracting, they are not shortening, they are not lengthening, just trying to hold a position of posture. And isotonic, which is involves dynamic muscle contraction. It means there is change in length. There is lengthening and there is shortening. We have shortening is concentric. Lengthening is eccentric. Concentric is when muscle overcomes the load, force, and the muscle can be able to shorten. Right? If the muscle cannot overcome, or the force, the external force, outweighs that of the muscle force or strength, then have lengthening, right? If I push, or the therapist push for example, the bicep curls. Example, I just want to give us some additional information. What we are used to is when we say eccentric, shortening, that's lengthening, right? And I think maybe this definition has now added some confusion. Say that when the force outweighs or that of the causes. Our focus is if, for example, there is a bicep, we are focusing on bicep curl. We are flexing the elbow. Have concentric work of biceps, right? And we have eccentric work of biceps. That is intermuscular relationship we are looking at two muscles. What you are going to be looking now is what about the muscle you are focusing, biceps, eccentric work of the biceps and the concentric work of the biceps. Forget about the triceps. Yes. So now, as the biceps is falling, yes, flexing, that is eccentric work. As you are going back, that is the eccentric work of the biceps. our focus now is on the biceps, not on triceps. It's not just that the opposite is going into eccentric, while the agonist is going into concentric, then the antagonist is going into eccentric. It's possible, but that is intermuscular relationship. But now we're looking at within that muscle. And we're coming to see some techniques that we apply that. Now we're focusing on just the biceps. As you flex, the biceps is contracting concentrically. As you are extending, is contracting eccentrically. And that's what we do most of the time. We ask our patient to do quadriceps training. We add weight. We just yes. The eccentric walk is very, very important. So it's not just centrically, biceps is flexing, then eccentrically, the triceps is eccentric, that's the antagonist is going into eccentric contraction. But within the muscle itself, biceps, as it is acting concentrically, is going to also contract eccentrically. And just the example I gave, that's why if we don't train that eccentric work too, we only focus on the concentric. Well, in our clinic, most of the time, if weight, we assess power is 5. You are not strong. But like the example I gave, just give you something heavier and ask him to drop. He's going to throw it because he cannot grade that eccentric muscle work gradually and keep it. Same thing with you ask patients to squat. He's just going to fall on the seat. That's because of lack of the eccentric work of the quadriceps. So when training, not just the agonist antagonist, focusing on the agonist itself, the isometric, the eccentric, and the concentric. And that's what we'll be looking at also in the PNF, in the techniques of the PNF. That's why I just decided to bring in this, add this little information on the As we're discussing about the techniques before the internet went off. Yes, I've mentioned based on the explanation I just gave on the isometric, concentric, eccentric muscle. Now know that sometimes we are focusing on the agonist, sometimes we are focusing on the antagonist, sometimes we are focusing on the glucose. That's why we have division of these techniques. And again, some techniques are purely agonistics, some are antagonistics, some are, they could be either, but they are just meant for relaxation techniques. They are just like relaxation techniques for pain or when there is a tensed muscle. So then we start with the agonistic technique. One of them is rhythmic initiation. Second type is combination of isotonics. You are combining eccentric, concentric from the name. Combination of isotonics, eccentric, concentric. So we are doing that to train mostly coordination. So you have replication, have techniques with stretch. Then antagonistic technique. Have dynamic reversals. We have stabilizing reversals. We have rhythmic stabilization. Stabilization techniques, we have hold relax, and we have contract relax. Usually for relaxation, for pain relief. Then look at one of the techniques for agonistic techniques. One of them is rhythmic initiation, and it has 4 steps. The first step is passive movement involved. It's purely passive, but with mental involvement of the patient. The patient is supposed to feel what you are doing. He's supposed to watch the movement as you are doing it. He's supposed to understand what you are doing. So it's purely passive, but with active, we say it's only active involvement all the time. Even though as you are doing passive, but in a way you need to engage, make sure he's part of it. He's watching it, he's doing it, he's getting to understand what you are doing. Then the second stage is assistive movement. You are going to assist the patient in achieving the direction or pattern of movement that you want him to do. Now you want him to go into anterior elevation, posterior depression of scapula. You'll be directing him, making sure he's going into that direction. If he's deviating, you'll be taking him, move slightly to the right, slightly to the left. Or the instruction is take your shoulder to the eye, to the direction of your eye, so that you understand that this is where he's heading. Then return. You go and return. It's assistive, but it's an agonistic technique. So you go with assistance, you return him passively. Because you don't want to involve the muscles that are involved in the posterior depression. You are only, for example, if you're focused, you have to focus on which function you want to see. Is it into the anterior elevation you want to strengthen? You want to help in the coordination? Whatever it is you want to do, for example. Okay? Because it's agonistic, you are only interested in the anterior elevation. So you assist him through anterior elevation. Passively, you take him back. You go together to anterior elevation. Passively, you come back. Then you go to resistive stage. At this stage, you now change your grip and you give resistance while he's heading into anterior elevation. While he has reached that, you are satisfied. You tell him relax. You take him back. Give resistance while he's going up. Relax. Take him back. Give resistance while he's going up. It's optimal resistance. You're supposed to be allowing to move. It's dynamic movement. It's not isometric. It's isotonic. So he goes up, you resist going up, relax, come back. That is the resistance stage. Then you ask him, okay, show me now. Do it, let me see. If he's able to do it, fine, you are satisfied. If he's not able to do it, you do it again, you repeat. Usually this rhythmic stabilization, the goals are learning and automation of movement. You want to give a very difficult technique or task start with how you want to show him the task. And this rhythmic initiation helps you demonstrate for him that this is what he's expected to do in all of the activities that we are going to do later. For example, you tell him that, okay, this is what I want us to do. You help him to learn, then you are going into another technique. This is like the basic technique. Anything you want to do the initiation first. Then you can begin to do the most difficult ones. Anything you want to do, start with the big initiation. Then you go to any other one. It's one of the easiest that you can do. So rhythmic initiation. From there, you make sure that he can do it. Then you ask him that, okay, now let's do a combination of isotonics, which is a bit difficult for patients. Yes. So maybe struggle, and later you're able to understand it. But at the beginning, you go for a rhythmic initiation, passive, active, assisted, resisted, then active. It's at that active that you know that whether he has learned the movement or not. Now do it, let me see. Does this and come back, now you're up. Or if it's going up and down, you know it's not going into the diagonal of the movement. You do it again. You keep on repeating until he learns the movement. And you can progress to another thing. So optimization of movements, normalization of the rate and rhythm of motion, and then rhythmic initiation. Improvement of sense of movement. It helps you to patient to know the sense of this is what you want to do. Regulation of muscle tone, of course, relaxation, intermuscular coordination, and so on. Yes. So these are just we're looking at elaborated steps of how you can carry out technique. Already mentioned, but we can go through it again. The rhythm and the rate of motion are determined by the therapist through verbal command. The command will be between yes, up, go further, too fast, slowly. You determine how he does it with your instruction. The passive stage, the therapist presents the planned intended movement to the patient. You have to tell him this is what you want to do. Relax, let me guide you. Feel the movement. Let me move you. Let me do it. Feel how, well, you understand, just sometimes that you understand that he's not supposed to be making any active contraction. Yes. 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 When you know resistance, well, you know when you heard of resistance, then you should be thinking of something pretty. Yes. Yeah. Yes. For the online audience, physical audience here asks a question if at what stage that we are supposed to apply this technique, and we have 4 steps. The second to the last step is resisting, which is the most difficult task because there's going to be involvement of resistance, and we know that resistance starts at power 3 is when we can go against gravity. So it means it has to be much above 3. Yes, but it doesn't mean that the patient, you have to go through all the 4 stages. They're all different patients. Some will come with 1, some will come with 0, some will come with 2. So where it stops, that's where you continue. That's what we just be doing. Is it 0? Is it at passive, active assisted? You just continue until it improves to where you can give resistance. You understand? So you just ask him to relax, need to guide you. There are other techniques too that we can talk about, like replication. There are if there is no movement, that you can do that. There are some techniques that if there is pain, if it's pain, there's what is limiting. When you do relieve the pain, like the hold relax or the contract relax, you relieve the pain, then you continue with the other techniques. Then if it's a coordination problem too, we also have some techniques that can help in their coordination. They'll also have maybe so that I will not even forget. Thank you that you have raised the question. There are also some aspects of the procedures which call the timing. It's also called the initial timing. This sequence of movement that I explained for the upper limb, for example, coming from internal rotation, extension, and abduction, all the way to flexion, adduction, and external rotation. Along the way, I told you that the movement is not just in the scapula. It's not in the scapula. It's not in the shoulder. There are movements in the elbow, in the forearm, in the wrist, and the fingers. We have not come to that. But along the way, you find out that it's the elbow that is problem. There's also a technique of rotation. You try to treat that elbow movement. You learn it, then continue. Or there is also what is called timing that I've started talking about. You have the initial timing in this sequence form, all through from beginning to end. That also was called timing for emphasis. Now begin to say, okay, it's elbow. Let me just focus on the elbow. This one, this time around is not repetition. It's timing for emphasis. Now apply some techniques for emphasis on that elbow. Is it the elbow flexion, or is it involving the pronation and supination, like having problem? Do this. Then you come back and sum it up. You see patient as a whole, integrate the patient as a whole, and you also break down into pieces. What are those missing pieces that's a problem? You just put them together, and you see sometimes improvement. So this is the instruction. Relax, let me guide you. Feel the movement. And second stage is the assistive stage. The patient is encouraged to cooperate actively with the therapist. They are supposed to do it together. Move with me. Help me with the movement. Let's do it together. All are instructions that you can help patient to understand that this is what you want to do. Going together. Let's do the movement. Help me. Let me assist you. Let's do it together. So you assist him. You do it together. That's the assistive stage. Then you have the resistive stage. The therapist applies optimal manual resistance against the active movement patient. Now you change your grip. This time around you are assisting. And now you are going to. But like what I mentioned earlier, for the passive, it's passive all through. Going into anterior elevation, coming into posterior depression. It's passive all through, of course. For the assistive stage, because it's an agonistic technique, you go through anterior elevation with active assistance. While it's returning, you ask him to relax, do passive. Go in with assistance actively, and while coming back, you ask him to relax, do passively. Then the third stage, you change your grip, you resist while he's going into anterior elevation, and you return him passively. You resist going into anterior elevation while he's going back to posterior depression. You do it passively for him, and you ask him. This is just an example of instruction. Work against my resistance. Push my hand. Something like that. Any kind of instruction that the patient can. So then the last stage is active. Patient does actively. Show me the movement. Show me the movement. Like what I mentioned, motion is passive. Motion is active. Return is passive. In this particular category of rhythmic initiation. Then we have combination of isotonics. Now you are combining eccentric, concentric. This is best usually for coordination, intramuscular coordination. So what are the goals? Active control of movements. Like we said, active control. Ask patient to tightly drop a bucket or something heavy. If the eccentric muscle work is not, if the control between the concentric eccentric is not excellent, you may end up throwing what's presented to you instead of keeping it tightly. Ask patient to sit. If the quadriceps eccentric muscle work is weak, you're going to drop into the chair instead of tightly sitting down. So these are some of goals for the combination of isotonics. Yes. Improvement of muscle coordination. This is what I was trying to say before coming this stage. We have inter and we have intra. Our focus usually is the inter, the agonist and the antagonist. But within the muscle itself, intra, centric muscle work and concentric muscle work. Increase the range of motion, strength, endurance, because eccentric muscle work is a very difficult muscle contact. The person has a very excellent eccentric, going to have a very good functional training. So it's easier to perform to do the eccentric muscle work while you start with concentric because it's difficult. I was practicing on one of the undergraduate students. I think before we finished, he was already the muscle was already shaking because it's weak. So eccentric muscle work is very difficult because the force is overcoming the muscle and the muscle is trying to maintain that position. So when you want to go for the eccentric, start with the concentric, then go for eccentric. Eccentric. When you start with the eccentric, you just be careful. So the steps again, the dynamic concentric eccentric, or the dynamic or the isotonic combination or the isotonic contraction. It's combined the activity of the muscle. Don't change grip. Stretch may be incorporated. You can use stretch just to let the muscle so that it act better. Eccentric is easier to contract, not concentric, just the same information. These are the steps. The therapist resists active movement of patients. That's starting from concentric. You resist going into concentric. For example, he's going into anterior elevation. Because that's the concentric work. While you also resist eccentric muscle work, same muscles going into vestibular depression. I know it's confusing. Maybe demonstrate with maybe bicep curls. And we have the subjects that I can demonstrate on the couch. The patient is asked to slowly return to starting position eccentric. There is no relaxation. The instruction is while you are going, hold, don't lose tension. As soon as you reach the end of the concentric muscle work, it's supposed to hold that contraction. You shouldn't release the tension. Then from there, now come back to eccentric. You still hold with the tension. Then come back to concentric. The same tension again. Come to eccentric, concentric, eccentric, concentric, like that. Let me demonstrate using the bicep curls with the elbow. I think it will be much easier. I think we should be coming from perhaps no, it's just physical. Please, can anyone just log in to see if can you see the online audience? Okay. So, for example, our target now is the biceps. For example, we are going to demonstrate to understand how you can give bicep eccentric, bicep eccentric. There's a combination of isotope. So let's simple as this, right? Let's so, like I said, there is no change in grip. Grip is the same, remains the same quality. For example, yes, the target is the biceps, right? But his physiotherapist, of course, say flex, you understand. Because just to call your attention, flex. Hold. Now, let me move you back. Hold. Now, move me. Up. Push my hand up. Hand up. Hold. Now, stop. That is, this device is muscular. Probably with the effective push. Up. Hold. Now, let's go back. You need to push against him. Let him go gradually. So it's active. Centrically going back. Give you resistance. Centrically give you resistance. Centrically give you resistance. Focus is not on the antagonist, in the triceps. You can see I didn't change. If I change grip, then it means I'm going to give resistance to triceps. I'm maintaining resistance to the biceps, all true. Concentric and eccentric. Okay? Yes, like what they said in the instruction, there's no relaxation. You shouldn't lose tension unless we are done. And we start with concentric. Then you are going to go to come back to eccentric. Then you go through concentric, come back eccentric. So it's clear now. Maybe somebody wants to do this. Maybe somebody can try to practice. Maybe we have learned it. Maybe you can practice on someone. Let's see. You have felt the movement like this. Okay, let's see. You can just use anyone. Okay, let's. Any of you can practice. Let's see. Good. Yes, so very easy for me to. So you now feel this is now eccentric muscle work and concentric muscle work of biceps. We're not focusing on you can see with the same grip, you have resisted bicep going eccentrically, and you have resisted bicep going concentrically. You shouldn't lose tension. The tension should be the same all through. So when you practice, from the instruction, there is no relaxation between the movement. The patient is told to stabilize and hold position at the end of range of motion. Then you hold. If you reach the end where you are able to achieve, hold, then return back, gradually. You are going to give resistance, but you should it should be the resistance that you are allowing him while returning. He's going to resist, but the resistance should allow movement. Yes, while you are coming up, we are the therapist giving the resistance, but you are allowing him to move through all through the concentric range of motion. Then he's now resisting, but he's allowing you all through the range. That is combination of isotones. When you have coordination problem, so most of the time this may help patients, especially neurological patients. Like the example I give, patients is trying to sit down, trying to lift. You can see most of the time we have neglected eccentric muscle work of many muscles. We most time focus on concentric work. Most times it's simple. So we can I think we can demonstrate. Maybe any one of us can volunteer so that we can. The subject is not here, so we can just will not waste time. Yeah, you can begin to see it physically, but not just through theoretical. Even though I try to just demonstrate few things, and we can go and. I want us to go with go to break. Starting particles attack, and we can be taking over. This online audience, we are arranging the couch for the physical One second. Wait for 1 second. New elevation. We are taking I said about the pattern serious how you grab your hand. The position is always also diagonal. That is also is diagonally aligned to the arm resistance patterns, everything. Option. Feel aware.
Como será? Vamos. Ah.
Double side.
Now we fully remove it. One, this is outline pattern. One. How
We can't see.
outline pattern.
We're not seeing the
One.
slide.
Hello, we can't see.
We can't see anything.
Can you bring up the demonstration? We can't see. And please, we can't see. We can't see.
We're not seeing anything. Can't see.
It's because I've not illustrated all the theories. That's why I don't want to.
We can't. We're not seeing anything online.
I know
Those
we're
online can't see. Online participants can't see.
That is, you can try combination. Let's assume that like I said, reading decision, any techniques you want to. Try to show how.
Please put on the camera for us to see.
And the camera is on.
We can't see anything. We can't see anything.
Okay, sorry. But it's on. I can see myself here.
We can't see anything.
From the organizer, they say it's coming up. They are monitoring the.
It's off. It has gone off again.
Sorry. I can demonstrate again. No problem.
I can see it. Just go to the Fatima little and click it. Sensation is.
We can't see you.
We can't see.
We can't see you.
We can't see anything. I'm not seeing anything.
The video is off. The video is off.
So we start to think. So thinking the main ones and that one's which is streaming compound, shifting passage, and it was and so the figure of the points glass. Yeah, let's figure out then we now have to use certified and we set for this. I can set over the settings. How far?
The online participants. Can we now?
No, we can't
We
see
can't
anything.
see. We can't see.
It's like the video is off.
There's other camera now.
It came on and it went off. It's off now.
There are three cameras now. Wait.
Okay.
Yes.
Can I start?
It's coming on and it's going off.
Sorry about that. It's the network. That was what I was doing during the presentation. I have to always go back to so that I'm carrying the online Can you now see any of the screen?
No. Yes. It's off. On. Off.
Yeah, it's on now.
Mine is off.
It's off. Mm.
What's up? What's up? And if you are on the laptop, it's off. On from the laptop is on. Yes. It's lagging. Or maybe yes, record is about this. Send it. That is a combination. That's with settings.
I can't pass.
No. especially for you can use it for strengthening. Yes, you can also use for coordination.
Also about progress
And
energy.
so now assist me going down
Energy.
and returning. I'm going to take you back. You are going to relax and take you back passively and assist me. Yes, back passively. Let's go and relax. Let's go and relax. Up or let's sit down now. Down and relax. Down or back and relax. Back and
sorry, the video is not still showing up.
And relax.
The video is not showing up.
I got video to like yanzu ko da muke sai ku tura musu to wannan ai da na fara video
We are not there. The same thing for so now go back to the so let's see the combination of associates. Push back, hold, push back. This is concentric. Hold, and let me push you back gradually. And let me go. You allow me to push you gradually. Allow me. Hold, and push back. Push. Hold, and let me push you and back. Up, and back. Up, and up, and you can see how it's doing the concentric switching. But we'll come to the eccentric push and back. Push and push and push and push. This combination of associates for scapular pattern of one in the direction of posterior rotation. Posterior rotation to scapular pattern of one posterior rotation to posterior rotation during initiation. This combination of associates. So we can try for upper limb for pelvic patterns. Maybe we do the pelvic pattern and posterior rotation, posterior rotation. They are just similar for the upper limb. Maybe of those illustrated. Yes. It's also anterior elevation, posterior elevation. You have posterior elevation and anterior depression. That's the two. We have not talked about the two yet. Anterior elevation, posterior depression. That's for the one. Into it is like yes, but into is the diagonal, not Anterior tilt is just straight like this, right? But this is just like you're walking. This is not how it works, but it's just a simple demonstration. Something like that's the anterior elevation and posterior elevation. Anterior elevation, flexible. Anterior elevation, posterior elevation, anterior elevation, posterior elevation, anterior elevation. One anterior elevation, one posterior elevation. One anterior elevation, one posterior. One anterior elevation, one posterior. The other one is that's every time. Let's try unit initiation. Take this by unit initiation. It's going to be passive. It's going to be passive. You are moving your whole trunk. It's just okay. And I'm going to do it. But you are not going to assist me. That's why you are also making the movement, because you are trying to assist me. Let me just do it. This better. Posterior elevation, posterior elevation, posterior elevation, posterior elevation. So now let's try not initiation. It's passive. That's the first stage. Now, second stage, we are going to anterior elevation. You are going to assist me, and you return passively. I'll return. Then you relax. I'll take you back passively. Up, relax, up, and relax. Up. You can see the way I place my hand is very convenient. Our assisting going up, and I'll passively return. This is leading, and this is assisting. This is assisting, and this is pushing, and this is the giving direction, and also the return. Up and relax. Up and relax. Up, up, and up, up, and relax. Up, and relax. That's second stage. Assisted. Then resistance. Because it's into anterior elevation. Up, relax, relax. Up, relax, relax. Up, up, relax. Up, relax. Now we turn back up, and now show me. Yes, fine. When you learn, you can isolate the movement. But you just start. How to do it? How to do it. So this is really initiation. You can try a combination of isolation anterior elevation. Now you go up. Hold, hold, hold. Now let me take you back gradually. Gradually, gradually. You let me move you back. Gradually, gradually. Up. See, there's no change in grip. And back. Hold, hold, hold. Up. Up. And back. Up. Up. Back. Now, if the patient understands this, you don't have to be holding. Why are you to hold? So that you don't lose attention. And with the same rhythm, you come back, you hold the tension, and go back. If you understand the instruction, you can be going just on going forward and coming back, essentially concentric. You understand? Like when you have to understand that you're not supposed to lose tension, then tension you go out and come back. That's one of the reasons now I'm not asking you to just go up and come back. So that's combination of practice for anti-inhibition. I'm trying to stimulate the question. Now it's back, and I'll take you back passively. Okay, we start with root initiation, passive state first. Passive. You feel the movement. This is how I want you to move. Yeah. Moving back and up and down. Okay. Now move down. Let me assist you. And you relax. Move down and relax. I'll take you back passively. Down and relax. Down and relax. Down and relax. Down. Relax. Down and relax. Now, another stage. Push against my resistance and relax. Push and relax. Push, relax. Push, relax. Push, relax. Push, push. Cast me like stick on my hand. Now show me the movement. That's the fact. Like I said, at this stage now, you cannot see down of the observer. You cannot see maybe mirror. Whichever way, he's feeling it, he's watching it, see actively, actively. When he's seeing it, it's much better. When there's a mirror, I see how it's as you said. That shows you are grounded and before coming. Okay, so that's combination. Okay, now combination of isotopics. So pelvic pattern is 1 into posterior depression, right? So now push against my hand. Push. Yes. Hold. Push. Push. Hold. Now let me push you gradually back. Let me push you. Let me push you. Push back and up. Let me push you and back. Let me push you up, yes, and up, yes, and up, push, yes, and up, push, yeah, push, let me push you up, and back, up, and back, up, and back. Are you tired? You know, because we're involving a certain problem. That's why I think it's really struggling to me. And that's the contact of your most specific. And you now know that yeah, you are doing too much, maybe you have done too much. So since we're here again, you can make combination. You can combine scapular pattern and palmar pattern. So we have done, we're not done the other level now, but what is available now, we can see how. Let's see how we can combine posterior depression of the pelvis 1 and anterior elevation of scapular. Yes. Let's go. I think you have got it. Yes, let's go.
Posterior depression of the pelvis.
Yes.
Anterior elevation of the pelvis.
Up. Relax. Up. Okay. What best can you do for this combination? can now say, okay, go up. And it's going to be difficult because it's web application. But if you do 1, 2, 3, that's fine. Go up. I'm going to give resistance while you are going into anterior elevation and push here and lift up. It's like you are opening wide and I will take you back. So let me resist you back. Give way here gradually and push up. Yes. And let me take you back. Up. You are not okay. You are not completing this. You get it gradually. Yes. Push up. Yes. Anterior elevation of scapula, posterior elevation of pelvis. Yes. Yes. So let me move you back gradually, gradually, and up. Yes, I think it's better. Gradually back, and up. Gradually back, and up. Gradually back, and up. You can do the same thing. Anterior elevation of the pelvis and posterior elevation of the scapula. And do different combinations. This is basic for math exercises. This combination, especially for patients, back pain, or the stretching usually. Those input. Yes. So I think we can take. I'm going to do this so that. No, you are tired already. Because there are so many phones here. How long? No, online participant, let them.
Okay. Okay. Hello. Please, we will be going for 30-minute break. We will be resuming at 2:30. 2:30.
Now, I'll give you the
Bluetooth mode.
I don't know if I'm going for this. Well, come on, let's move it.
And okay. I'm gonna eat something participants going to invite you. But I don't
Amal. Ki zo mana. Na ce ki tattara kwanon nan kika kama yayin ka tafi. Kun ci abinci ne? Kin ci kifi? Eh? Na tukunya kifi pepper soup. Eh? Kawo filan wannan abu. Ki store za ki kai shi ki ajiye. Kawo filo nan mana. Kuka kike yi ko me? Ne ki nema ɗan kunnen ki kuma ki saka na gaya miki.
Yeah, I'm a very practical person. I don't like too much. Okay? I know people have read this theory. Okay, you want before this person.
Yani. Okay.
Hello. Yes, we are back. Yes, we are back from the break. I'll continue.
Back in the game with upper limb function tests with Dr. Ian Gadd. So shall we meet Ian? Ian is a very well accomplished upper limb injury specialist in the UK. Has over 23 years of experience.
Oh, can we continue?
So
Okay.
Ian has played a pivotal role in advising Olympic and Paralympic sports, and he has dedicated a significant amount of his time leading sports science and medical services for the Great Britain Boxing Program, guiding athletes both through multiple Olympic and Commonwealth Games. Ian also offers private consultations on complex upper limb injuries with both athletes and non-athletes, and he is widely recognized as an exceptional educator in sports upper limb injuries.
I want to continue. Yes. We have mentioned that there are different patterns, upper limb patterns, lower limb patterns. Derived from the upper limb and lower limb patterns, we have the scapular patterns from upper limb. We have the splenic patterns from lower limb, which have demonstrated the first diagonal, which we have demonstrated the first diagonal for each of them. We have demonstrated the first diagonal for the scapular pattern, going into anterior elevation and posterior depression. We have demonstrated the first diagonal for the pelvic patterns, anterior elevation and posterior depression also. So we'll now be looking at the second diagonal for the scapular patterns and the low and the pelvic patterns also derived from the upper. Now we're looking at the two of these patterns. So the second diagonal is posterior elevation and posterior depression, as displayed in the screen. Posterior elevation and anterior depression. So it's posterior elevation and anterior depression. Posterior elevation and anterior depression. Posterior elevation and posterior. So it's related to the second diagonal also of the upper limb and the second diagonal of the lower limb. You can see this is the second diagonal of upper limb. The activity we see at the shoulder is flexion, abduction, and external rotation. Flexion, abduction, external rotation. And have the opposite. Let me go straight to the upper limb. Yes. So this is the can see the one in red is what we have as the first diagonal that we have done. Flexion, adduction, and external rotation. We have anterior elevation occurring at the scapula. We have the second, the opposite, which is the external extension, adduction, and internal rotation. Now we have flexion, abduction, external rotation. Anyone can demonstrate. Flexion, abduction, external rotation. Is in this diagonal. What we have first is this diagonal. This is diagonal we had first. So it means what is coming second is on another diagonal. So it means it's going like this in this direction. I mean, this is the diagonal first. We need to know where it's going into direction. Where we had first is this is the let's take it gradually. This is the one, flexion, adduction, and external rotation, extension, tension, extension, abduction, and internal rotation. That is the one. Where we have anterior depression and posterior depression. Now is so this is the diagonal, right? So it means the second diagonal is going to cross it from the other side. So from this direction. So that's how the hand is supposed to look like, the movement, right? So we now begin to look for flexion. We now begin to look for flexion. We look for abduction, and we look for external rotation. This is the external rotation. Oh, this is external rotation. Oh, this is flexion, external rotation, and abduction. Yes, and this is extension, adduction, internal rotation. Yeah. Okay. Look at the, well, that's why I have this summary. So that before we come into the upper limb, we can reduce the impact. So that's why we started with the pelvic and scapular patterns, then the shoulder, before going into the other joints. So we have said the first diagonal is one, okay, they said they cannot see. Okay, they cannot see my let me stand up.
Hey, presenter, we can see you. You can go on. We can see you.
Okay. Yes. So we have demonstrated the first diagonal initially, flexion, adduction, and external rotation. When you have anterior elevation of the scapula, that is U1. U1 also, we have the opposite direction, which is extension, abduction, and internal rotation. Or you have posterior depression of the scapula. Now we want to talk about the D2, because we want to isolate the scapula and pelvic pattern also, like we did in the first, like we did in the first diagonal of the scapula and pelvic pattern. So when we look at the pattern of the second diagonal, this is the first diagonal. So it means the second diagonal cross the first diagonal, also diagonally. I see. So we have what we have marked there in blue, that is the second diagonal. We have abduction, we have external rotation. Then we have coming down to extension, adduction, and internal rotation. But between this, we have posterior elevation of the scapula, and here we have anterior depression of the scapula. As you can see it visible. Please respond if you are still listening to me. Anyone should respond online. Okay, so we have posterior elevation, and we have anterior depression. Same thing with the pelvis and the lower leg. So we now want to demonstrate the pattern. We'll now apply rhythmic initiation. Apply also that of the pattern. Then so this is the first diagonal, anterior elevation, posterior depression. Now the second diagonal is anterior depression, posterior elevation. The same thing. posterior elevation, anterior elevation, posterior elevation, posterior elevation, anterior elevation, anterior elevation, posterior elevation, posterior elevation, anterior elevation. So, what demonstrates movements, technique, making. Supporting that we get passage when active assisted, returning passage because it's an agonistic technique. So up, assist me, let's go together, let's go forward together, and yes, relax. Up and relax. Up and relax. Up. You can see my position. I'm also in that diagonal position all the time. I was here initially, only in front also, and I'm here now also in the diagonal direction. So up and relax. Up and relax. Up and relax. Up and relax. So now go to the stage. Push, push, relax, 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 relax. Push, relax, push, relax, push, relax, push, relax, push. Now show me scapular pattern into posterior elevation. Now we try combination of isolation. So now push, this is concentric, push, 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 hold, hold. Now let me move back gradually. Let me move it, let me move it, let me move it, let me move it gradually. Up, push, 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 hold, hold. Now let me move back gradually. Back, let me push it, let me move back gradually. Push. Yes. Hold, hold, hold. Now let me push it back. Up. Yes. Down. Down. Up. Down. 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 Up. And down. Combination of seconds, right? Into posterior elevation. Now anterior depression. So going to anterior elevation. This is movement. Go down, up, down, up, down, up. It's supposed to be passive, but it's passive stage. Yes. This is the direction of the movement. This is the direction of the movement. Then the resistance, we give it also to the other side. Go there. Whichever way is aligned position. So now, let me assist you. Down and relax. We're going into attribute integration, active assisted and assisted back. Active assisted and relax. Actively assisting and relax. Actively assisting and relax. Actively assist and relax. Actively assist and relax. Now, want to do resist. Push. Take your elbow down. Push and relax. Push and relax. Push and relax. Push and push. Push. After this anterior depression, scapular pattern into anterior depression. Make initiation into anterior depression. I want to try the combination of possibilities. Now, push down, yes, and then we back gradually up and down. Let's go, push. Now, let me move you up, and down, up, and down, up, and down. So you choose scapular pattern into anterior pressure, combination of acid. I also do something for the pelvis. So something. Yes. Maybe, yeah, maybe after you are able to learn or to isolate the yes, because this is just anterior elevation, posterior elevation. We have not taken the direction of any technique. We don't anterior depression, posterior elevation. So now let's start with the posterior elevation. So make initiation. So let me do it passively for you. This is the movement I want you to do. This passive movement. Okay. After being passive for quite some time, then you now switch to the active assisted. So now you assist me, pushing up and you relax. I'm going to do it completely passive for you, returning, coming up, we'll do it together. Then you relax, I'll take you back. Up, let's go together and relax. Up 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 and up. Relax. Up. Relax. Relax. Push. Relax. Push. Relax. Push. Relax. Push. Relax. Push. 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 Show me the movement. So this pelvic pattern into posterior elevation. Make initiation. Oh, now we can look at the combination of messages. It's not. I think is okay. So now combination of isotonic, push, and you hold, then you push it back gradually. You are supposed to letting it go gradually. Push back. Yes. Hold. Now let me take you back gradually. gradually push and back. Then you allow me to push you. Gradually. Allow me to push you gradually. Then push against my resistance. I'm letting you go gradually and then you go back. So that's the zero equation. Every passes. Then anterior depression is the same way to movement. Same way. Then relax the speed. Go down. Relax. I'll take you back. Down and relax. 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 Now, give resistance. Push. Relax. Push. Relax. Push. Relax. Push. Relax. Push. Relax. Push. Push. Now, do it at same pattern. Same pattern into anterior depression. So now, combination of isotonics. Yes. Concentric. Push. And hold. Then let me take you back gradually. Allow me to push you. Yes, and hold. Then turn back, push against my resistance. Push against my resistance. Now hold. Now let me take you back. Hold and push. Back. Let me push you back. And push. Back. The whole world, all true women are doing eccentric skills. So this is not even patience. That's what I yes, you have to. So I think one applies. This is it. Yes, this one. Also, I know. And I think the visual depression. Because if I place my hand here, it's not going to be anterior depression. Understand? That's what I'm saying. This of you understand what I'm talking about?
What is the elevation? Right? And the other one should be at the,
If I'm supposed to in the opposite direction. Right? Yes. Yes. Like this.
What do you do? Try to put actually your white straight. Yes, that is
Okay. Can anyone demonstrate this pattern so that you can practice that? So I will not just be anyone wants to finish. Initiation or combination. So we move to another technique or another anyone just one demonstration of 2 minutes. Say you want to answer the question. Anyone?
Wayannan dai kun rike ta sosai ko ba ta faɗuwa. Sai dai ko ɗaurewa.
This movement is from the elevation, posterior elevation, and this is anti-depression of the combined using the passive movement. This is being really passive movement. But if we are to do, I wanted to do the combination of antics, but now just the supposed to okay, this one is here. Yeah, we need to make it. So let me just start. Okay, just another. Okay, now as you said, let's go together. Okay, now we are going to do the okay, I want you to be together. Let one know don't do this before together. Okay. Everybody good. Now come back. So I'm resisting the movement. I'm resisting the posterior elevation and I'm also resisting the anterior depression. So now for the fourth level of the reasoning, it's going to be 3. Okay. So the movement is not is the one we are going with time to get it straight.
Thank you. Now we can upper limb. 6. I've said the upper limb pattern is one mention it. That's why I started with scapula and kept on referring to it before we come down to it. Now we are coming down to it proper, and our concern now is just only what is happening at the shoulder. Initially, it's only what's happening at the scapula. We said at the scapula, there's only anterior that is posterior depression. Now, what's happening at the shoulder is we have flexion coming up, we have adduction, and we have external rotation. Right? It's coming, they are all coming together. So flexion is coming, then again you rotate, now adduct. They're all coming together. You are heading to adduction, you're heading to flexion. Don't worry about elbow, forearm, wrist, and so on. So now it's just anterior elevation, sorry, upper limb pattern 1 into flexion. Upper limb pattern 1 into extension. Upper limb 1 flexion, upper limb 1 into extension. And we have flexion, adduction, extension. We have extension, adduction, and internal rotation. So while you are starting, you are going into flexion, extension, and adduction. You start with extension, abduction, and internal rotation, all the way to flexion, extension, and external rotation. If your aim is in the direction of extension, abduction, and internal rotation, you start with flexion, abduction, and external rotation, all the way down to extension, abduction, and internal. So that's how you see in the text, in the videos, in the media. If the pattern is named extension, abduction, they will say upper limb pattern 1 into flexion, upper limb pattern D1 into extension, upper limb pattern D2 into flexion, upper limb pattern D2 into extension. Clear now? Yes. So that is how the patterns do. If you are starting down from the opposite, you reach to the just demonstrate for this. Upper limb flexion D1. Upper limb flexion, upper limb flexion, D1 extension. Upper limb flexion, D1. D1 into flexion there. Upper limb pattern, D1 into flexion. Yes. Upper limb pattern, D1 into extension. So, lie down. Fine. So, I'm going to clear. Yes. Now, reduce just right? You said
because you don't calculate.
No, that's how we started gradually. We come gradually, we will reach there. I know it's confusing. Even if you leave this place today, you open it tomorrow, you start thinking which one is you want, which one is two, and so on. But you try to revise it all the time, and most of us are able to get. I mean, online too. Yeah. So if you need to practice it over the time, you don't have to plan it. I'm not cramming. not classical leaders. It's just you have the idea, then that's all. So this is flexion, adduction, and external rotation. And extension, adduction, and internal rotation. I'm only focused on the scapula, on the shoulder. But we are still at with our scapula. This pattern is a problem. That's why especially situation. I will just start with pelvic scapular patterns. Because by the time you start properly, you'll be going back to scapula. You will be going back to pelvic. If you are done with them, you are now progressing the patient. Right? You understand? So passive, passive, and relax. Relax, relax. Up and relax. Up, relax. Up and relax. Up and relax. Now resistance. Let's go up. Go against my resistance. Up, 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 up. And relax. Up. You're supposed to go up. You are resisting going. You're supposed to go against my resistance. Okay, I should go. Yes, you should go as far as far as you can. Up. Yes. Go to resist you. Up. And relax. Up. And relax. Up. And relax. Up. And relax. Last stitch, which is active. Now, up, 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 up. Now, we are supposed to go actively up and understand, and we go back up and resist me. Yes, resist. Go back and up. I'm not changing. And up hold. Now let me move you back gradually. And hold. Now you go, I'll go against your resistance. Hold, now against, yes. And up. I'm going to resist you. Yes. Now you are going to resist. And combination of aspirin. Upper limb, you are going to flexion extension. Do the initiation extension. So illustrate the movement. Same thing. Going and off. All the way coming to the active assisted stage. Focus on going to extension. Now go down. I'm going to assist you. Then you relax. I'm taking back passively up. And this is between windows. So down and relax. Go down and relax. Down and relax. Go down and relax. Down and relax. Down and relax. Go down and relax. Now relax. Relax. So I'll take you passively and you go against my resistance. Yes. Relax. Resistance. Relax. So naturally, without the relief initiation, it's upper limb pattern 1 into extension. Then also apply the combination of aspirin. Which are going to go. Yes, going to resistance. Hold. I'm going to move you up. Just relax. This is the movement. Here. Up. Start. Back. Here. Back. Right. Push. Yes. And relax. Then you are going to resist by pushing. Yes. Going back. Yes. And going to resist. Going to push you. Now going to resist you. Then I'm going to resist. This upper limb can lead to extension or with elbow flexion. You see it's more advanced. What is happening in elbow or elbow flexion? We are not taking that from school. We go to lower limb. It's one also. without flexion. Adoption. That is the same like that one. What do you have there? Flexion, adoption, and extension, abduction, and extension. And we have anterior elevation. One. We have posterior elevation. And we have posterior elevation that we did. Two. Anterior elevation. We have anterior depression that we just in the belly part. So, or did you get that? Let's not adjust it. That's what we do. Like I said, it's the same part of one, but because the other aspect of both one. So we have to keep I will have anterior elevation. We have posterior elevation. Flexion, internal rotation. Starting flexion, abduction, internal rotation. Okay, let's start with we have not done the one for the lower limb. We have not demonstrated the one. Flexion. Flexion. Yes. Abduction. Yes. External rotation. External. It's just matter of understanding direction. Is it? Yes, and that's why I said also there is technique with flexion. You can there's technique to just be extended, and there's also a technique with flexion. I don't want to bring all this troubles now. Whichever one, there's no any problem. Okay. So that's the flexion, adoption. We have flexion, abduction, adduction, and external rotation. Extension, abduction, internal rotation. It's clear, right? And yes, this is external rotation. And this is extension. Abduction. Sometimes in position. Right? So for the D2, we have done well with the D2. How can you direct from anti-direction? Let's look at flexion, abduction, internal rotation. Abduction, yes. Internal rotation. while you are watching, it's also supposed to watch. It's also supposed to even the one you can give him a feel or something for you to see the lower movement you are applying. All the techniques you are applying, the pattern you should watch. Trying to see how you do your part. I know it's difficult for some neuro patients because it's also part of training of the neurological conditions for them to be following, especially visual training, for them to be watching. That's one thing I forgot. And you can combine. I mentioned combination. There are lots of ways you can combine. I'll just demonstrated few now. The combination can be different ways. You can combine. We have made a combination of pelvic and scapular pattern. You can combine two upper limbs, but you also need to identify which pattern and the direction. And that's what gives rise to the and give rise to more confusion. Because you mention whether it's bilateral, symmetrical, reciprocal, or it's bilateral, asymmetrical. When you do this, going into the same direction and coming back, it's bilateral, symmetrical, right? But if you do this, it's bilateral. Is this symmetrical or asymmetrical? Are they on the same diagonal? This is the one. This is the two. This is the one. Yes. But they are going in the same direction. But sometimes you also demonstrate they should be doing in different opposite direction. They are in the same diagonal. They are different diagonals. They are bilateral, of course. Different diagonals and reciprocal. They are not going in the same direction. So you see this combination. You see this combination and terminologies too. Okay, let's add another thing. We have done two agonistic. We have not done any other. I think it's not fair. We should have to maybe one or two. Oh, you are tired? No. Okay. Another technique is maybe comprehend. This is because many activities we combine these patterns. You can see it's a combination of patterns. When you play golf, when you want to chop something, you combine the patterns. You also use the train equation. You also apply. Don't forget to apply. Not anything. You also is getting it. It is taking it and give the direction of how to do it. Yes, it's possible. So there are different combinations. Yes, you can be combined patterns. Combination of scapular, patterns, combination of limbs, and values combination. Upper limbs, lower limbs. Yes, we can also combine the lower limbs with different patterns. So these are how we use bilateral. Both of those bilateral symmetrical, reciprocal, bilateral asymmetrical, different direction. So yes. just demonstration. So should we go or out in another 10 minutes, 15 minutes? I think like that. Okay. This time for someone to you don't need to practice. Yeah, this is very, very complicated. And in the format of the course, you should have to you give about 3 months to come back. Yes. You have to go and practice. Over 2-3 months, I think a month or two, I can't remember. Long time. I think it's when I do this. So you go and practice for about 2-3 months, then you come back. Then you finish up last. That's how you that's how I see it. So even the first one, I was confused. They are just doing everything. But it's just gradual. Okay, because it's just half. It's 100. It's 100 hours. So 50-50. I remember in how did I put it in post 6, 7. We believe that cases. How did you calculate it? How did I put it down? There are so many breaks. Later you come back for the second one. It's because you can see fish and everything. Yes. Just gradual. It is gradual. When I went there, just say, let me take this.
It's not eggs.
Yeah?
It's not eggs.
No, it's not. I have lots of money, but I just decided to go. Yes, because I was not.
Don't say what I create yung ba maan. The one who can abuja. Parents are never. Paano yung ewan na nga ho. Ayan kacil na yung bag. I can away the network. On it. I don't know.
We're waiting for a teacher. Alexa.
I went to see her off. My auntie, my small auntie. I know that.
Every mother does that, okay? That's a new story. Time that you're writing the story, she has already given that. There are proof that she gave birth. So the fact that they're telling you to write the story means she gives birth, okay? So you don't have to write it again. Get the same thing. But listen to
People have left.
There's a shark over here. Come on, it's not a shark. It's tiny. Yes, it's a baby shark, but it's still a shark. It's not. It isn't. It's not. Yes. Well, I see you're a shark. And you're my shark.
I'm fine.
Oh no, it's a shark. Everybody.
The toilet side and in the hot water. Also, and I turn the hot water so that everything will mix very, very well before I'll start washing the toilet so that everywhere will just be at once. I started washing from the hot white plate because there was terribly dirty. I have to put a lot of clean there again because there was
also combination. Which one for the orthopedics? Low back pain, strengthening, coordination, coordination. Anything as a low back. This back technique, what depends? Like I said, they generally let's say flexion. Flexion, attention. Now we are going to resist. I'll take it down like this. Now then go up and this is centric. And this is the concentric.
Wani abin zai ji muku ciwo ba.
So let's take since you are tired, change inside. Let's not look at the antagonistic techniques. Antagonistic techniques we have mentioned stabilizing reversals, dynamic reversals, and release. Those are the things we mentioned last time. during the introduction. I know you cannot remember. Because the extension, direction, so these are two I mentioned earlier. Dynamic stabilization, or sorry, stabilizer reversals, dynamic reversal, and position. So starting with stabilistic, the stabilizer reversal. Goal is stability and peace. Something of muscle coordination. This one is intact. For functional activity, within the muscle, centric, concentric.
Nan ba na ganewa.
Not
Papa.
it's not the best for but
Wai irin wannan a WhatsApp a laptop. Ni laptop din tawa ce ne. Ya hankali. Zoom. In na samu better laptop.
apply approximation for commencing starts with remember positive positive approach. Yes, yeah, positive approach. So switch to antagonist pattern comes without using multiple action. End up with that one. Start with better one, the end of the better one. One of the hand therapies contact and story. Power for one to help ventilation between done in the combination of acetylcholine and communication. So if we are to apply the scapular, for example, one anterior rotation. So what we do is say start with the stronger side. So you can ask him push against my hand. Push forward and the anterior rotation to find out which is stronger. The anterior rotation or posterior rotation. Let's say the posterior rotation. Right? So push, posterior rotation, push, push, push. Now hold, and push forward anterior rotation. Sorry. Let me check this one. Stabilizer. Sorry, I'm doing the so we can just continue. Because continue is stabilizing. There is no movement. Dynamic, then go to the range of the movement. Yes. I'm already going into the next one instead of stabilizing. So if it's stabilizing reversal, yes, let us perform it. Hold, and go into anterior rotation. Up. Hold. You can see antagonist. Start with the stronger side and end with the weaker side. This is dynamic. Dynamic reversal allow for movement. Go up. Hold. Push back.
Pàtàkì bí mo ṣe ń bọ̀ ló ti bẹ̀rẹ̀ iṣẹ́ gbàrà níyà ọpẹ́ o.
Ẹ̀kọ́ wà títàn lẹ́nu.
Kúrẹ̀ ló bá tún.
Hold, and push back. Like I said, the instruction, there should contact all the time. Now two, change, go back to two, change it again. There is contact with the patient. There should be resistance all the time. You should do this tension. So these are just the distance. I think they are very much too complicated. Dynamic reversal and stuff. movements. So this antagonist, you see all of those ones we have the grip is just on the agonist. Don't take it because you have possibly agonist. Everything has to do with muscle that direction, right? Whether elevation or elevation or flexion, extension, or into elevation, to whichever one that. But in this one, we are changing it to exit of other to exit the antagonist and come back to the agonist. You see the antagonist. So either you allow the movement, the dynamic reversal, or you make it static for the stabilizer reversal. So the goal is to increase stability and balance, strengthening of muscle coordination to apply. Possible to apply and apply population dynamic reversal, active motion changes from one direction to the opposite. So you can see there is motion. That's one of the difference. The goal is muscle coordination, muscle regulation, respiration of muscle. These are the steps. Also, question. Techniques. Inside, I'm just the difference when you yes, it's just as it's like symmetrical in the stabilizing process. Just you make sure you don't make any range of motion, just like just making movement just like symmetrical. But the other one is concentrically, concentrical. But this one is really you are focusing also in agonist. So it's like concentric. So you focus on the agonist, then you now goes back into concentric. This one is movement, all through range. So this one is the main fix, just isolated. And then stabilization. Yes, that's all. This no, taking go. So by extension, this is the whole event that has upper we are limited to shoulder and scapula. But by extension, you have still the shoulder. This was trying to show the pattern and what happened with the shoulder. Then you have the elbow and do with flexion, like I said, flexion. And then you have wrist flexion. Then you have then you have fingers flex. Then you have thumb flex. Then same thing with again the opposite extension is the opposite. Elbow flexion or flexion, wrist. This is supposed to be forearm. Washing the forearm extension, wrist extension, there's elbow flexion extension, there's finger extension. Then this is the one. Then we have these are all activities. So what it means with that normal time dimension is what happens that then when you want to understand the whole pattern of the file, we are going to apply what right from beginning, what is supposed to be done to the fingers, wrist, and then and that's what we have to observe those sequence of relationship rules and also reverse fact. I also was time for I also said this elbow flexion and relation to flexion. And now we begin to strengthen the nation now nation as simply form. That's kind of exercise. Let's say this many part like we program there now says in the site. And for then work on this other operating anyway you have problem, you break it down and make sure that this is better. And you put it, you don't have to create all of the movement patterns from people because correctly. Whichever where you find that, that's where you find progressing your so the same thing is all the activities on the tools, foot, ankle, knee, any questions?
It's time to tidy up the kitchen shelves too.
I now see the next question. I think like I don't think I don't even know any stretch. There are lots of that. Stretching helps the to stimulate the process. If the patient is losing power and using strength all the way, having stretch, just stretch the muscle joint, then you can have more contraction. So you can see this sort of effect also catching physical fitness. I believe that they are not applying and like I said, that was why this guy wrote this.
A little better.
That's how you wrote this thing. So now, systemically, you can look, if you want to add information, you know, like looking for upper limb 1 pattern, you are looking for lower limb 2 pattern, you are looking for A, C, and so on. At least by today now, maybe something else. And I post the seminar. Every practice will take time. Maybe the way we have the perception, the way we view, the way we see, read, it's now the change. I think this is foundation. What I will do. Do you have anything we can contact me? My number is I've been doing that many friends and for this don't experience WhatsApp or the office. So thank you very much. So thank you very much to online participants. Any question or clarification? Online participants, you can write your questions or you can say them directly. It can be read so that I can respond. Thank you very much. I think it's from the department the therapist is like the department of physical therapy. And of course, it's very common in Europe, so it's most likely to start to general causes. Highly concentrated in Europe. So, how many of you so that I can write it possible? There is another question. Close the session. Thank you very much. I'll send the materials, I'll send the slides. If you need it, I'll send the book that I'll send it to you. I think the last seminar I sent all the slides and I'm presenting this. I'll send it to you. But on some things that I cannot send them, like all these simulating because sizing them as well. Because I don't have permission to use. So when I edited questions, before the week, I shared.
Someone is asking.
Okay, somebody asking question.
How do you carry out piano concept on acute patients? Thank you.
I will now, after, if you're able to see patient, you now write that this is the pattern you have applied, the body parts, the technique, the diagonal. Yes, there's a question on how do I apply PNF on pediatric patients? Yes. I'm just displaying the slide currently. The PNF is it's in different categories. They have the basic 1 and 2, then the advanced 3A and 3B. Is at the stage 4 that one will be involved in the 3A or 3B. That is where tricks is involved, which to sincerely tell you, I've not done the 3A, so I have not come such information. Thank you very much.
In the next, what about timing and frequency?
Timing and frequency. The timing for the exercise. This depends on the patient. It depends on the patient, and it has to do also with regular patients. There shouldn't be fatigue, of course, and yes, there shouldn't be overtraining also. So those things should be taken into consideration.
Happiness. That small aloe vera, don't plant them. Okay.
Small one.
Share that someone where I plant.
So thank you very much. Thank you.
Sannu, me yake a kicin?
Har yanzu suna nan?